They receive personal care services come day or night.
Stick it under the chair. Because that's where real people are. Maybe put it on the bookshelf. Oh, there's the screen. I wish I could reach.
I think there are a couple more people signing in, so we'll give them a chance and then we'll go ahead and get started.
Does anyone object if I audio record?
It's old school lunch. Old school lunch. Okay, so I think you can hit the key. Okay, just to make sure that everybody's just there. So just to be clear, is everyone okay with the video camera? If you're not, please let us know. I'm already talking. Yeah. Okay. I just want to make sure everybody else has an opportunity. Okay, we'll go ahead and get started. Welcome, everyone. I'm so glad everybody could make it out today. It's very lovely outside, so we won't keep you too long. But today we're here to host a public meeting on the Behavioral Health Intervention Services Coverage Policy. My name is Christina Bakar. I'm here from the Agency for Healthcare Administration and Food Medicaid. I'm joined by Judy Pickle, Ann Dalton, and Eric Boyd-Thomas. And so the purpose of today's meeting is really for us to include you all as our working partners in developing this coverage policy. And so it also allows you to participate in the rulemaking process by giving us your feedback, comments, and those kinds of items. So if you have signed in to speak, I think there's a speaker sign-in sheet. We are hoping to get to everybody today. If anybody didn't have a chance to sign in, you can go ahead and Cole has the sheet. You can add your name to it if you'd like. If you want to give us any written material, you can give that to Cole as well. He'll collect that. If you want to email it to us afterwards, we're happy to receive that in that vein as well. Okay. Oh yeah, for the rule record, it's rule 59G-4.370.
So thank you again for joining us today. We're very excited to have you here. We've talked a lot about some of the changes that the agency is proposing around the services, particularly our services for behavioral health services. Many of you all have been with us as we worked to redefine and to reorganize our policies. So today we wanted to talk about our behavioral intervention services. So this is born of a number of things. We've kind of talked to you about where we're going with our policies and the direction we're taking in mind. So I'll just give you a brief overview for those who have not had the privilege of understanding the direction that we're taking so that you're able to follow along with us as we go through this. So like Christina said, today we really do want to receive feedback and comments from you about our policies, but we want to first talk about our approach to our policies. If you're familiar with our community behavioral health service policy, you know that is comprised of a number of things. We've taken that policy area and it's converted into like bite-sized pieces. So we have behavioral health therapies, we have behavioral health assessments and evaluations, we have behavioral health community support services. So all of those components have been broken down into smaller bite-sized pieces. Our overview and our goal with that is to make sure that we speak about the service before we were focused more on provider-specific coverage policies. So as we move to something that's more service-specific, we want to make sure that we group like services together. So you see that Florida Medicaid has a vast array of behavioral health services. So today we want to focus on intervention services. So we want to walk you through a little bit of the work that we've done, but most importantly, we'd like to receive feedback. I think we received feedback from some providers in advance of this about some of the work that we've done, particularly FABA gave us feedback on our behavioral analysis services. I'm not certain if we received any comments on Behavioral Health Day or TBOS, but those also are services that we're contemplating with our behavioral intervention services. So our goal was, because the feedback that we received from you all, we wanted to have a policy area that reflected just a broader range of array of services so that you can see it collectively together. So we didn't want something that required you to read 180 pages to be able to understand when we pay for a service. Additionally, we looked at what is our purview, what is the responsibility of the agency. But as a Medicaid agency, our job is to talk as a payer system. So specifically what you saw that has been removed from those policy areas is us describing to you how to be practitioners, how to deliver services, how to provide care, because that's not within our scope nor within our purview. I know before we spoken about scope of practice. So we pulled back from identifying or trying to explain scope of practice. That is the Department of Health's responsibility and not the agency's responsibility. So with that being said, we wanted to talk about those three service areas. So for us, behavior interventions, having that group together to those three policies, Behavioral Health Day, from 2 to 5 years old, TBOS, you can have upwards of 9 hours of TBOS for all ages. And then additionally, we have applied behavior analysis. So with those services, we've heard from you that you want more clarity around documentation. So we'd like to enter into the discussion with you. This is more open. This is not really for us to present to you, but more so to bring ideas from you all. We would like to know surrounding documentation or things related to the coverage of the actual service. What can we do to make our policies clearer and more crisp in these areas so it's clearly identified who the service is for? We have a couple of areas that we continue to address in our policies, which is number one, who can provide that service. So we speak of who can provide that service. We are just picking up from Florida statute who is able to provide the service. We are not making judgment calls about who we think is best to provide that service. Again, we have to operate within our legal authority. When we talk about our legal authority, that's derived from Florida statute. That's also from federal CFR. So things like that that would help us shape our policies. So we have who can provide the service, who can receive the service, what exactly is that service? So when will we reimburse you for those services? We identify when we will not reimburse for those services. So as we talk about this today, we want to hear from you because we know that we've gotten comments about our policies being lean. The policies are lean because we wanted them to be a cover-to-cover read. We wanted to have greater readability, and we wanted to make sure that was for a broader audience. Before we wrote policies that were specific to a specific provider type, we have a number of individuals who actually pick up our policies and utilize them. It's very challenging if it's a parent who's picking that up and trying to understand what services are available for their child. It's also challenging if you're not a provider and you don't understand some of the terminology that we use. That's just our Medicaid terminology. So we stripped all of that away. Additionally, we had things incorporated in our policy where we've had specific ICD-9 and ICD-10 codes. We pulled that back. We've never seen your patients. It is not for us to make a determination about who best needs this diagnosis. We don't want to limit the diagnosis that you utilize for the services. So those things have also been removed. Before we used to repeat things over and over again because we thought that would provide greater emphasis, but we found it, well, you told us it was confusing. So if we restate things 3 different ways, it was challenging for you to understand what we meant. So we will only state things one time. What we additionally used to do in our policies is we used to have information from other agencies or from statute. We will not cut and paste or copy or pull over anybody else's information into our policies because, again, we can direct you to whatever we're using as our legal authority for you to review it. Additionally, it gets updated and it easily becomes stated. So if we have something in our policy that requires you to do X, Y, and Z, and that no longer is in statute or 42 CFR, then now you're out of compliance with state and federal law because our policy under administrative rules states something different. So those are the things that we've done to refine our policies. So we understand that community behavioral health services for themselves are unique services. So we want to make sure that we have enough depth and breadth to what we're writing, but we're not so restrictive that you cannot do what you do best, which is deliver services. So I would like to open up the floor to get some feedback from you all about our policies. So we're talking about the policies as they stand today. If you have questions, comments, concerns, or thoughts or ideas about how we can enrich the policies or things that need to be clarified, we'd like to hear from you. So I'm going to open the floor. That's enough for me. Yes, Karen.
So the issue about documentation currently in the 3.9 handbook is that you can do recoupment if we do something wrong, but if it's never stated what we're supposed to be doing, referencing the general documentation handbook isn't helpful because it has a laundry list of things, many of which are like if applicable, if applicable, if applicable, which can also be confusing. So if there are certain documents you want us to have and that we need to keep on file and that we need to keep for 6 years or 5 years or 7 years or however long it is, then that needs to be stated. So I think that's an important thing.
You're advocating for more specificity on the types of documentation that providers must maintain and the time frame for that.
For a particular service, yes.
So we're going to capture what you're asking for. Let's see that. So we can make sure that we have it covered when we move forward with this. Thank you for that. So we actually have been looking at documentation ourselves, trying to identify what is appropriate. Are we overlaying things? We did renew all that. Some of the things that require documentation wise are a bit dated. So we're trying to pull a little bit back from that because with medical practices and services, things are ever changing, ever evolving. So we are going to update our policies. Our goal is to update it every 18 months, but realistically, the rulemaking process does take some time, especially if we want to have public meetings and things of that nature. So we've been working the community behavioral health coverage policy. Some people say 6 years, but I just want to clarify it's not been 6 years, it's been 2. So we did get that feedback. It's been 2 years, but that's because we really do want to have feedback from our partners. So with that being said, when you talk about documentation, it'd be really helpful if you all could give us a little bit more specificity on the types of things that you'd like to see within the policy that you feel are reasonable. Because we have lots of thoughts around that. I mean, we've taken down the applied behavior analysis textbook. We've looked at other payer systems. So we've done a lot of work trying to figure out what's the right fit. So we need your help. Yes, Colin.
So for the Medicaid waiver, they are required to do quarterly reports for the clients that have developed a disability and those kind of things. So if you guys are thinking about grouping any of these together and they for any of those requirements, we already have a ton of indirect work that we have to do. We cannot do. And so if y'all are going to continue with that mentality, please give us some indirect hours so that we can supervision adequately and also develop the research data.
All right, good point. So that really wasn't something that would concern any reports, but more so specifically just identify how would you document a service? How are you documenting progress? What types of things are you maintaining for your clients? What can we refer to if we wanted to know if services are being provided? So I know if you look at our historical policies, you will see specifically in the community behavioral health policy, if you look at the 2012 version of that, where we really do have a lot of information on there specific to what we expect you to document. So I'm asking today, is that what your preference is? Does that give you greater comfort to have specific things identified that we expect X, Y, and Z? Or would you just like us to have a broad stroke that kind of says that we expect that you have a minimum have documentation that supports the following?
I think X, Y, and Z, and I know for us, it would be like in progress notes, perhaps billing logs to the evidence that is actually submitted. We also use a third-party software called Web ABA. There's a bunch of different ones like that that are required. For example, you can capture parent signatures. So I would, posit that that's a better solution than we get the parents to sign digitally on the phone every time it's a unique signature. So parents or caregivers log a session and say, hey, that actually occurred.
Thank you for that comment. I appreciate it. Yeah.
Right. You were asking for ways to make the policy clearer.
Yes.
I think specifying the 3 levels of people
Okay.
that right now they're kind of lumped in together. It has a list of providers and it has a list of things that fall under PBOS, but it's not, there's not co-referencing. Like therapy has to be by master's level.
Gotcha,
Behavior
gotcha.
management has to be by this type of people. So the way it's written right now, a technician could be providing therapy services.
And that's not our intent. So
Right,
thank
I
you.
knew
Okay.
it wasn't, but
Yeah.
that's kind of how it reads.
Okay.
There's a lump of providers and a lump of that, but there's no referencing who can do what. Is a problem, I think.
Okay.
The other thing about the documentation is, in the ABA policy, there's an appendix. So there's rule that's hard to get through and you don't want to change it. And then there's appendix, which can be changed. Maybe we could have all the documentation requirements in an appendix so that the rule doesn't have to change every time requirements for documentation change.
So we do have those appendix, like appendix 9, it is in rule.
Oh, it
So
is.
that
Oh,
still
okay.
is
So
part
it's
of
the
the
same
process.
thing.
It's the same thing. We
Oh,
just
okay.
want to make sure. And again, like we saw before with our providers, when we have massive manuals, we were only reading like one chapter, not understanding the applicability to all chapters being combined. So we're trying to make sure that it is a cover to cover read. Thank you for that feedback on TBOS. Yes, Bruce?
Besides the documentation issue, I think, an updated handbook on the rules whenever there's a rule change is essential because, the last handbook that we had was October 2017. And I know for months starting in 2019, I kept trying to call people at Medicaid, including I got a hold of a supervisor in your department, Medicaid Bureau Policy, trying to find out if we could bill in the presence of home health aides, because I wasn't sure if that was in the same category as SLP, PT, OT or not. And I still haven't gotten a clear-cut answer. And even when I was talking to a supervisor in Medicaid Bureau Policy, he said, I don't know, let me get back to you. Never heard back. Or refer to the handbook, and the handbook's October 2017.
So we will update it every 2 years. So reasonableness, right? So the rulemaking process does take us about how many months? So 7 to 9 months, but with the public input and feedback, it can drag on for a little bit longer than that. So I understand your concern about specific scenarios, but it would be very challenging for us to have every scenario identified in our policy. So what we try to do is we try to capture that in the exclusions. So under section 5.0, if something is prohibited, that's where we'll state that. So if it's not stated blatantly, then our intent is not to have that as a limitation. So we will always be clear when something's being limited. So if it's something that you cannot do, just to be clear, it will state that you cannot do that.
So are you saying that if it's not explicitly in the handbook, then yes, it's okay?
So that is how we approach our policy.
Okay, I'll be sure to remember that, because I know we get, there's a potential for us to have to give back any monies that AHCA feels was improperly billed. We don't even know that rule was even in place to begin with. So if we have that on the record now, that if it's not explicitly in the handbook, it's okay, then great, because I've got 3 clients that we haven't been able to serve for 6 months because I've been trying to get an answer to this question. So that would help me considerably to know that now we can bill in the presence of home health.
So again, like I said, in our policies, we're going to identify who can provide, what the service is, who's eligible, and if there's something that you cannot do that's considered an exclusion, we will have that in section 5.0. You know, understand the challenge of us trying to come up with every possible scenario that there could potentially be in terms of billing. We understand that there are times when services may overlap, but of course, we want to make sure that it's our responsibility to look at reasonableness. So you may have questions about that from people who do audits, which is not us. So I can't speak to their role and purview, but it's to make sure that we are just being fair and equitable with taxpayer dollars. So
Well, right, and even as before 2019, we were able to bill with other professionals like OT and PT. And then all of a sudden I find out from my billing person that no, you can't do that anymore come 2019, and I never got an update about the rule being changed.
and the agency never released anything that stated that was included.
So it's, I mean, are we supposed to be Miss Cleo and just know what is and what isn't okay? I mean, we have
Of
to know.
course not. You know, our expectation is to make sure that we have policies that are clear. That's why we're having this discussion today, so that we can further clarify and identify if there are areas that we need to refine, so you don't have to guess. So thank you for your comment.
So is the 39 service going away? It's going to be subsumed into?
No.
Okay, so it's
No,
still.
No changes to provider types. This really is just, again, like we said, for us to clarify our policies and to make sure that we're showing a comprehensive array of services. So oftentimes, like specific things like TBOS or behavior analysis, those are modalities. And generally for Florida Medicaid, we don't really speak to a general modality. So if we have occupational therapy, we don't speak about occupational therapy in a specific way of modality of occupational therapy. We're not talking about applying therapy or any other way that can be applied. We really talk about more broadly about when we pay and when we don't pay. So that's what we're trying to do with these services. So this is where this becomes a little bit challenging, the area of community behavioral health, because we do have specific modalities that we're trying to address in a policy area.
So if, the reason I ask that is because there's a couple of things. First of all, I would recommend, because the AHCA opted to use registered behavior technicians for behavior analysis, and we use BCAVAs, that there be a notation that that the procedures follow, like for supervision, et cetera, follow the behavior analysis certification board.
So you would like more specificity on, you want supervision included?
Separate supervision should be indicated as required by the behavior analysis certification board, because the BCAVAs and the RBTs, they only keep their certification if they have the appropriate supervision. And the appropriate supervision by the behavior analysis certification board is either a BCBA or someone who's been authorized by the BACB to do supervision. There were a number of people who lost their certification, or they're not RBTs anymore, and they have a 6-month wait period before they can take the test again, because they were following, or their providers were following the handbook, how things were stated in the handbook regarding supervision as opposed to the BACB.
We actually didn't say anything about supervision.
It stated that licensed practitioners, everyone who was a lead analyst could do supervision. And so people took that to mean that if they were an RBT, that like a licensed mental health counselor or a psychologist could do their supervision, but that person hadn't been in the handbook, and the original one with the behavior assistant, where it had the behavior assistant and it had the RBT. The licensed people could do supervision with the behavior assistant, because that isn't anything that's under the aegis of the behavior analysis certification board. But the RBTs could only get supervision from BCBAs or BCAVAs per policy, their policy of their credential. So I would stipulate that the supervision follow the behavior analysis certification board, and that way, if there is a change to something with the supervision, then you're already covered in the handbook. You don't have to make an update. It's just any supervision needs to be done according to the BACB. But the thing too is that anyone who's using an RBT, whatever company is billing for the RBT, should be responsible for their supervision at no cost to the RBT or to the BCABA. I don't know how much of it is going on now, but I do know there were a number of RBTs a few years ago who were concerned because they were doing services with someone who couldn't do their supervision, and they were told they had to find their own supervision. And they're a paraprofessional. I don't know many behavior analysts who are going to do supervision with a paraprofessional who's implementing behavior programming. And now the VACB has indicated that the behavior analyst needs to be have a contractual arrangement with the company or whatever of whatever cases that they're supervising. So again, it kind of follows the VACB, but I think whoever is billing for the RBT needs to do, they're responsible for making sure the supervision occurs, and it shouldn't have to cost the RBT or the BCABA to get supervision.
So just to be clear, you want inclusion that, so for the service to be billable by Florida Medicaid, an RBT must be supervised. You want us to cite that the certification board, consistent with the certification board.
It's because the RBT reviews the credential otherwise.
Understood.
Yeah.
Yes.
RBT is listed as one of the providers. In the T-bonds, RBT is not one of the providers. I don't know if that was a deliberate oversight or it was just, it wasn't in the old handbook, so it didn't get in the new one.
I know, I think, with the, old RT bus policy is, so that was before there were RBTs. So
Right.
definitely something for consideration. And you had a question, sorry.
I actually was just going to make a comment about the documentation. So we actually had a site visit from MPI, and while she was out, I had asked her, like, what exactly needs to be included? Do we need parent signatures, which I know that has already been brought up, but so the way that we have our service logs, we list all of their program struggles or maladaptive behaviors, and then we just do a short summary for each session that we work. She was unable to tell me what actually needs to be in there. And so I think the concern for most providers is if we do get an audit and we submit that, if we're missing components that you guys are looking for, that we're going to have some type of recoupment issue, or we're going to have, suspensions or those kinds of things. And so just understanding clearly, like, I think agencies as a whole are happy to provide you guys with whatever we need to show justification for our services. I also am not opposed to parent signatures and those kinds of things, but like, we don't know how to instruct our staff to even how to fill those out. And then when you call and ask questions, nobody can even tell us. And so there's just such a disconnect that we're not really sure, like everybody's kind of doing their own thing and then hoping that it's right whenever everything kind of blows up. So, if we could have more clarification on that, I think that would be great.
We can definitely add that to the component of documentation. So.
Sorry.
Yeah.
I didn't know if there was a limit on how many times you can speak.
You've already met.
Yeah.
Got my quota color off. And I was going to actually start referencing the T-bond proposed policy that's out there is 2.2, which is on page 2. Says who can receive. It does not have in there under age 21. But somewhere later, it kind of implies it's only under 21. Is it still planning on being under 21?
Yes.
I thought so. It's just not
So
clear.
T-Boss is under 21, although our health plans are actually covering it for a broader audience and really the expanded benefits. But as a state plan, it's still under 21, so I think bring that out.
And also, it looks like, because you had mentioned that, you were going to be restricting on diagnoses, but it looks like the primary diagnosis could be a developmental disability.
So we actually are not speaking to diagnosis, so we haven't ever specified who can receive the service for a particular diagnosis range. We really want it to be medically appropriate. So that's the challenge. Before historically we did have those ranges that we identified, but what we saw was that in order to be able to receive reimbursement, providers were only using those diagnosis codes that were described in the policy, which was very restrictive because if you had someone who could benefit from the service but did not have this diagnosis, you felt compelled to use the diagnosis. Or we had people who actually had to go through the process to access the service through special services, and that wasn't our intent. We have to go and request the service through a unique way to be able to have something that we know is a covered benefit for children. So that's why we did remove that. So our goal really is just to make sure that it is age appropriate. Is it clinically appropriate?
Okay.
I was just gonna say, I think that it would be very beneficial to have it, again, very XYZ outlined, what exactly the definition of medical necessity is for you. I know that there has
Oh, we do
been,
have that defined. That's defined in our definitions rule. It's very clear. We have 5 bullets to that, and there's an explanation to how we view medical necessity.
I'm sure that everybody in this room can say that they have submitted things that they absolutely feel meet medical necessity requirements and continue to get them pushed back by EQ Health. Even recently, for literally having EQ Health respond that they don't approve. Sorry. Okay, maybe that's done.
No, we don't want to hear.
We've been, literally within the last week, people have gotten programs pushed back under the statement that EQ Health does not approve experimental treatments.
So if you receive those and you have concerns about the approval process, of course, you know, you can go through EQ Health for reconsideration, right? But we're also asking if it's just a continual complaint. To use a complaint hub, that allows us to track and trend things. So we can specifically have pointed discussions with our vendor about their approach. And we can further dive into like what's going on related to that actual authorization for that recipient. So if you do that, that would be very helpful to us. I'm sorry, it's the back of the room. Apologize.
What was your name? My question is, what is the facility set up for to provide food options? So I was informed that in order to provide services, I need to hire a psychiatrist, etc.
Wait, I'm sorry, I don't
To
understand the
provide
question.
TBOS services, I would have to have a facility and hire psychiatrists.
So to provide TBOS services as an independent provider. So TBOS services is a part of the community behavioral health provider setting. So we haven't changed who can provide the service. So if you were associated with a community behavioral health center, then you can provide TBOS services. So these services are still not standalone services. The only one that can be provided independent of that, that we're speaking of today, is applied behavior analysis services. So that has not changed. So that has always been our longstanding requirement for the Medicaid, for the delivery of that service. I think Jane, you had a question?
A couple of points, if you don't mind. In section 3.2.1, we list the practitioners and their licensures for, and we'd like to include chapter 397 among the statute citations and set some substance use providers. And you list them, you know, as a category, but you don't have this active records stuff. Section 3.2.2. And I think we've expressed this before, we agree with we'd like more clarity in terms of who can provide, mostly because we don't want to see unqualified providers delivering services that are outside of their scope, but I guess, you know, we've been on the record on that one, that's like, that first time. In section 4.1 coverage criteria, we think it would really help, and I know that we've heard that this is problematic for AHCA, but when you mention medical necessity criteria as defined in 1.010, we put a hyperlink to that policy in the coverage manual, since we're accessing online. That way, you can have sort of instantaneous. Oh, so this is what it says. Because
we actually have hyperlinks for other areas, so we'll do that.
Okay, good. The last time we asked, they said that was problematic. In section 4.2, actually, no, I'll retract that one. So section 4.2.2, and I heard you say that TBOS is not a covered service for adults, but it can be an in lieu of service. So that's
no, not in lieu. It's an expanded benefit that's be provided by the health plans.
Okay, so then for non-state plan services, services under the covered through the managed care plans, that it makes it tricky because if you deliver TBOS to an adult and reimburse the health plan, they can deny it. So if it's allowable for adults, it'd be nice if that was just be allowable for adults as opposed to an expanded benefit. But I know that you probably already included that. Yeah. Just providing feedback from our members on the things that are important to them. Exclusions in section 5.0, the handbook specifically lists provision and travel time as service that Medicaid doesn't pay for, but there's no such exclusion in the TBOS plan. So does that mean that billing for supervision and travel time are allowable under TBOS?
No. Yeah, that's an exclusion.
Section 5.2, another non-covered service. If you are a behavioral health provider as opposed to a behavioral analysis provider, you don't always know when a person has received behavioral analysis services. So it says you can't get behavioral health, therapeutic counseling, trauma-informed counseling on the same day that you get PA services, but our folks might not know whether someone has been seen by a PA. So it really puts the burden on the provider whose client may or may not be able to remember or articulate that they got already seen. And so then providers are at risk for providing a service they can't get paid for. And the plans have no choice but to deny it, because I think that that's something that it's an undue burden on providers to be able to know what is happening, what else is happening in a person's life that day. And then you can provide the service and not get paid. Section 6.0 under documentation says that providers must complete a certification form every 6 months to verify the child still meets criteria for TBOS. That's not in the manual. Is that still required, the certification every 6 months? And also submit these in writing so people can.
Yes, it would be great to get those in writing, because I'm like ferocious, like taking notes here.
Yes, I will email them when I get back, and that's it. So thank you very, I really do appreciate all of these forums that you've had in the meetings. It's very helpful. And I think we finally understand where you're going, what you're trying to accomplish by tearing down the handbooks, and it does make sense. So thank you.
Well, thank you for that comment, Jane. I appreciate it, because we really did. That's our overall goal. So if it doesn't make sense and it's not usable, then we haven't met our goals. So that's why we went up this discussion today. I'm sorry, I don't know your name.
I just have a question. So the draft that a lot of us are like referring to, now is the intention that that also is going to be the draft to include the coverage for AHCA services?
So we're thinking about having those included as a component of that draft that you last saw. So you saw a draft on the behavioral health day and then TBOS services.
Yes.
So, and I think it's titled differently. Does it say behavioral interventions?
It does not. That's why I wanted a little bit of clarification as to,
Yeah.
because that whole ABA section is missing out of it.
Yeah.
So it was a little
Yeah.
concerning that if we were moving the direction that ABA was going to be included in this document, so it should probably be included in the document.
Right. So the reason we did not do that is because, just being totally transparent with you, is the fact that we got lots of feedback that when you come to forums like this and we give you documents that are already prepped and performed and ready to go, that you believe that this is the policy that we plan to move forward with. And it really isn't. It really is for us to have something for you to react to provide comments. So we tried to do it a little bit differently this time and not have an actual draft. So there is no behavior intervention draft for you to see. We wanted to more so talk about the concept and get feedback about the concept of having this be a more comprehensive policy area and your thoughts around it, and what at a minimum should it contain, which things do you think are just significant and are just a must, or things that are like, we must have this and these other areas are nice to have. So that's why we didn't give you a draft.
So moving forward though, your goal is to put a behavioral health intervention service coverage, which will include ABA within that document.
Yes.
Okay,
So
and are you moving to like change any of those, like the allowable hours and things like that?
No, nothing of the sort like that. But as you saw, I don't know if you participated when we discussed assessments and evaluations, or behavioral health therapies, or behavioral health medication assisted treatment. You see that we've broken it all down. So we have our residential services grouped together. We have all like services grouped together. So we did that on the side of our practitioner services, and it was just well received. It was something easy for those who wanted to look at labs, radiology, or other areas, where they didn't have to go into this massive book to figure out like what's billable, how to do it, how to go about it. So we really wanted to address all intervention services that we have available in a different way. So we're hoping that you will give us feedback on that today. Does that make sense? Do you understand the direction that we're going? We did have a diagram of how our policies were arranged. I don't know if we can pull that up for you to see really quickly, but it's just a diagram of behavioral services that we have every area that we cover. So that's clear that we cover just this vast array of services. And that we thought like the way to do it was to have a comprehensive policy, but we do realize and acknowledge that having a massive thing, you're not reading it cover to cover. And we did see specifically when doing like reviews or technical assistance, information that people had not read or weren't aware that it actually existed. You wanna do that?
So when Erica was talking about the policies and kind of the concept in reorganizing them in that manner, one of the things that we have
A little louder, we have a fan right here and it's hard.
what, you're in a wind tunnel?
Yeah.
Okay, I'll stand up and that maybe will help you. So as Erica was talking about the policies and the concepts behind reorganizing the policies, one of the things that we hoped also to achieve was to make more clear that there is a range of intervention. Every intervention, when they're separated like that, it makes it hard for people to understand the concept that you have a less intensive, less restrictive intervention, and that there are other steps in between that and the most intensive interventions that there are. It gets really difficult explaining that to folks and having them understand that. And when they see that, it's very disconnected in their mind. They don't think about policies having or issues having the ability to be treated under different types of interventions within a range.
I think the issue with that is that as behavior analysts, when we assess a child, we're not going to tell them, oh, we'll try speech first, like see if maybe that works, and if it doesn't, come back and see us in 6 months. And so
No, that's not the
when
intent for that. So, I mean, just to be clear, I just want to make sure that we're clear on what we're trying to do. Like, we just want to make sure that everyone's aware that we do have just a comprehensive package of services. And I think sometimes that gets lost when you only have just one bit of information present. So we're not asking you to say to your clients, we're coming to you with a prescription, we've been evaluated, this is the service that they need, no, I think you should go elsewhere. That's not what we're saying. It's more so for us to be able to show that, hey, look, there's just a broad array of things that you can access and your child can benefit from. We have, residential settings. We have, targeted case management. So we're actually even taking the targeted case management policies and having those all aligned so you can see that we have child health services targeted case management. We have mental health targeted case management. We have substance abuse targeted case management. So all the targeted case managements are together. I'm ahead of myself on what we want to cover. So, but that's really our goal.
Well, when we submit our plans, they're almost all of them are being pended back. Like, it's virtually impossible to submit anything to EQH and get an approval on the first go around. Like,
And
it's
a lot
just
of
a
them are
constant. They're
saying
pending.
have other less expensive prohibited, like interventions been tried, has this, like, so it's just, actually, we're one of the ones that got the one kickback that said that, this does not meet medical necessity because it's considered experimental treatment and didn't actually request any information further, but then also said, again, and we're getting a lot of them kicked back that say, have other mental health, things have been tried, behavioral,
Lesser intensive.
like, where it's getting kicked back, like a lot of them. So if we're not getting those feedback all the time, like that, we really should know. So part of our medical necessity no buttons. Hands down. It's very easy. I don't know. It's you're irritating, but no. So if you look at our medical necessity definition, you walk through all the bullets of our medical necessity definition. So one of the things it says is that I think that the problem that they're trying to express to you, microphone, is at least costly alternative, has the least costly alternative been tried. So that's something we do for every single service that we cover, be it nursing services, but therapy services, a surgery, eyeglasses, dental services. That's like one of the standard things that we do as Florida Medicaid. So that we have this limited pie, we have an array of services we're trying to provide to everyone. We must comply with EPSTT. So one of the things that we do is we want to make sure that, hey, are you aware that we have these services, but also too, if you have, just identify that. But you actually should not be getting anything back from EQ Health that says experimental or investigational. So we would love to get that information so that we can work on it. Yeah, absolutely. So if you could please, don't put it into our VA comment inbox, but if you could get that to us through like using the complaint hub, or if you don't want to do that, we can give you one of our cards so you can send that to us so we can direct that to EQ Health. So we can address
one
that.
of the greatest challenges that I think everybody here has had is, if
there's questions on a case, that's okay, but it feels more strategic than based on individual cases. We have a room of people who are saying, everyone that I sent in.
Everyone.
Well, when you have a physician refer a case for some therapy, the question from EQ Health should not be made to the provider. It should go back to the physician. Have you tried everything besides ABA therapy first? Because it puts an onus on the ABA providers. You know, we're stuck in the middle on this. The physician feels there's a need, feels like we're the best avenue for results. He refers it to us, and EQ goes, well, what else have you considered? It's not our place to consider that. It should go back to the physician. And that's what EQ Health needs to think.
And by submitting the plan, we're saying, by submitting a plan, we are saying that it is medically necessary. By submitting the plan, we're saying this is the most appropriate intervention for this child based on our professional opinion and our assessment and the data and the doctor's recommendations. Like, so by saying like, you need surgery, but have you tried this? Well, I could die in 2 weeks, but we need to make sure that there was, do you see what I'm saying? Like, if it's been referred by a physician, we have the diagnostic from the neurologist, and then we do a full assessment that is so detailed that says, these are all of the reasons why this child needs this service as opposed to this, then why would we then have to defend further? I guess that's like, it's frustrating.
And when you're talking about other diagnoses, right, perhaps there's more for it there. But when it's autism, this is the only recognized, scientifically recognized treatment for autism, so it feels like it's questioning science, which becomes.
I think the other issue to tag along with that is when we are getting pended for, have other services been considered? Sure, they have, and then it asks, provide us with documentation on how well it was. I think at that point, when we're starting to talk about documentation and what we need to keep in their files or whatnot, is that then out of our scope of practice? If we're applied behavior analysts, I don't know how well speech was because there was a referral for ABA. Yes, we can do them in conjunction with each other, but EQ Health is pending everything saying, okay, well, yes, you're providing ABA services. How's speech go? And we're supposed to provide documentation on how that's going.
The
And I
speech
don't- I think-
pathologist should be providing that. There's a lot of complaints about EQ Health, but not about health.
Yeah,
Right,
so
so
I mean,
that's
so
just
just to be clear,
documentation.
so I do appreciate the feedback about EQ Health. And I know we only have an hour, so I would like us to redirect back to what we were here to talk about, which is the policy areas. We can definitely take the concerns if you have waste about EQ Health back to them. We do have a responsibility in my bureau for the contract with EQ Health, so we do interact with them continually. So for us to get this feedback is helpful. It's also very helpful for us to be able to track and trend those complaints by using our complaint hub. Then we can actually quantify the number of times that you have been pended, quantify if things are being experimental or investigational. So when we hear these things as a one-off, it's very challenging for us to go and say to them, hey, we think there's some practices that need to be reformed because we don't have enough information. So we like you like, we like to have data. So if we say, you know, this is the 15th complaint about the same topic, then there's something that we need to do to address this. You know, not to say that just because there's only one complaint, we're not going to do anything about it, but you know, quantity, right? It does matter. We can have that discussion. You've been very patient with me, on, so I want to get your comment. Okay.
I think one other.
So I just want to, you know, I want to, because I want to make sure that we can address the things about the policy. So if we can just come back to the policy, we will have plenty of opportunity. We're having a number of public meetings that are broader, but this one's very specific to the policy.
One other policy thing that's up there that I think needs to be addressed is if AHCA's goal is for supervision to be top notch. I think right now y'all have the same standard as the BACB when it comes to the 5% per RBT per month across all clients. But some cases may require 10% or 15% because either the client is more severe and we need to do more, or maybe the RBT may need more training. So we need to go out more to ensure the supervision is top notch, but we can't bill with our RBTs. So we're paying the supervision hours out of pocket. So if we want to discuss whether we can bill with other licensed professionals like SOPs, OTs, and whatever, let's have that discussion. But I think at a bare minimum, we should be able to bill in conjunction with our RBTs, especially on cases where we may, in our judgment, feel it needs more than the minimum 5%. But if you don't let us bill with our RBTs and we have to pay all of that out of pocket, we're going to bill our rate, but then even then, we have to pay them out of pocket. They can't bill. We're not going to want to do more than the 5% fair supervision within the law.
So we actually don't speak to supervision in our policy or have a percent right now, but your comment about supervision is noted. Our supervision has been structured the same way across all practitioners, regardless of your physician or nurse, and they're in the same room, only the physician's able to bill. So this is how it is structured for Medicaid. That's how it's structured for a number of payers, where the lead individual is the one who actually bills. That is also billed as the supervision time, but that's definitely something that we.
I know at one time we were able to bill in conjunction. That's no longer the case. So I'm just simply requesting
that
we
was
bring
never
that back.
contemplated, to be honest with you. It was never contemplated that there could be billing by the lead and also by the assistant and the RBT at the same time. Our full intent was that the highest paid individual in the room is the one who bills. Like when the physician's in the room with the nurse, the physician bills. The same thing when we have OT and PT. So if there's a physician, a physical therapist, a physical therapy assistant, the physical therapist bills. So I just want to be clear. I know that you're talking about that. I just want to let you know that I know we've gotten some comments that there is a distinction being made about the practice of applied behavior analysis. It actually is the same across all of our services. So I just want to clarify that.
Well, no, but I mean,
I get your point. I understand what you're saying.
There may be some people who are providing services like an SOP, but the behavior of the mutual client is really bad. So they may need an ABA person to come in and help with teaching them ABA strategies for behavior reduction. But I'm just saying that's a whole separate issue. I'm just saying that we should at least be able to bill with our RBTs like we were able to up to 2017, so that we can ensure that, especially on cases that require more supervision, we're not having to pay extraordinary amounts out of pocket. If you want the supervision to be top notch, then we should be able to provide that instead of just making sure we get the minimum 5%, because it's going to be all out of pocket.
Understood. Thank you. That was under med waiver. Rules are different for waiver.
State plan.
Yeah, but the state plan was based on the med waiver,
Oh,
which is why it allowed it. But anyway, okay, so
Which was a part of the cost plan. So we don't have a cost plan. It would be really challenging for us to figure out a percentage of the billing. So when you have a cost plan, you could say up to 25% of the bills, but you don't actually have a cost plan because it's open to whatever the needs of the check.
right. Okay, so
we have 10 minutes left, so my timekeeper is reminding me.
all right.
So just to be clear, some people signed up to speak. I just want to make sure that everyone who signed up to speak had the opportunity to speak. If you didn't, we'd like to dedicate the last 10 minutes to those who did not get a chance to speak who signed up. Let me know if you want to waive this or if you want me to read off the names and again.
Okay. Marie Soleil.
That's me. I think the majority of the things on my list are somewhat explained away by the complaint about EQ Health. And I promise you in the next week, you will receive a lot of complaints about EQ Health. That absolutely, I will disseminate that information and that will move forward. I think
Do you want us to send you the complaint hub link so you can just go into
Your email here.
We're like,
Oh,
oh,
yeah.
drooling.
But actually, I know the business part too.
Absolutely. But then I think the one thing that I would really like to say to you guys is that, this meeting moved forward very quickly, and the meeting for Friday moved forward very quickly. And I think that because it was scheduled somewhat abruptly, the notice was a little bit short, and we're not being provided a call-in link. I think that you're really limiting access to providers. I know for a fact that there are a lot more providers who wanted to be here who are not able to participate. And I'm a very small agency. I can tell you it is absolutely problematic for me to be here and participating, but I understand how important this process is. So I'm taking that time out of my paycheck, out of my day to be able to participate. I think it's absolutely essential that we open up that accessibility, make sure that there's call numbers, make sure that we're giving ample notice so that everybody who wants to participate has the opportunity.
especially like this week, to expect people to be here today. And then I'm gonna drive back to Orlando and then drive back here on Friday. Like, I want to be a part of this. I'm a new agency. This is important. I think that most of us are extremely grateful that you guys are open to our feedback. And so it's super important to me to be able to be a part of that. But like in my mind, I didn't even know that there was a meeting on Friday. And so I'm already trying to process, like, how do I go back to Orlando and then try to get back here on Friday? So I agree.
So one of the things we tried to do before, when we were first thinking about like making the proposals, the changes to what you're talking about for applied behavior analysis, we did say, we're like, we will have a number of meetings, but we did expect for this to begin, you know, much earlier in March is what we were projecting. And I think we tried to notice this 14 days in advance to let you know about our rulemaking meetings. So we did notice it 7 days, but we can take into consideration the fact that we do want your participation. We do want to hear from you. So definitely something that we will note to make sure that it's clear. We are putting this in our FAR notices. We're also putting out provider alerts, but we will make sure that we take that under advisement, because again, we do want your participation. So we thought we were going to have meetings Wednesday, Thursday, and Friday. So once we determined that at this time it's not in our best interest or your best interest, we heard from you that with the rates to even begin looking at rates or having discussions about methodologies or things of the nature. So we actually canceled that meeting. So our goal was to have it in a row, so it wasn't like an up and down situation. But once we noticed it in our court administrative register, we couldn't pull back and change Friday's meeting. So I do want to apologize for the inconvenience of that.
We can also receive comments via email for our full comment box. Slips right back.
So if you have this comment paper, you know how to comment on the rule, and we would appreciate if you would take the time to comment. You know, you can share as much as you like. Colin actually has Cole has extra documents so that you're able to do that.
Okay. I think Colin Streetman.
I'm sorry, she had a
I know,
question.
but we're going through the list.
No, I don't have questions.
Okay. Colin Streetman.
All right, thank you guys so much for hosting this. Again, I briefly want to jump on what Pearson said. I don't think he elucidated the situation clearly. We are not necessarily looking for supervision to meet the standards required by the AHCA. We understand that 5% falls on us. What's happening? Autism is 5 times more common than boys than girls. This field is 80% female. You have aggressive, violent teenage males right now that companies won't touch with a 10-foot pole. Why? Because you need 2 people to help that child. And then we can't do it. So now we got one person, we either put a petite woman in danger to work with a highly aggressive male, or we take a client that we cannot possibly make money on, that we are just serving as a nonprofit boss. So to serve the community with the most difficult disabilities, we need to be able to, in some instances, conduct an MDT and say, wow, this client is putting people in the hospital. This client has been arrested for violence. He's going to need more help. We've got to bring severely violent, aberrant behavior down to a safe level for an individual practitioner to service that child. I also want to touch base. If T-Boss is open to community behavioral health situations, I can see where you guys are going with this. Everything's under one. The agency, well, have you tried T-Boss? Have you tried this? You're going to need to delineate the fact that ABA is provided by BCBAs, where you're going to have a bunch of community behavioral health clinics that are putting what somebody said, the master's approved providers out to work and do quote unquote ABA. So what they're going to do is they're going to say, hey, okay, let's do T-Boss with this master's level provider. It's not a BCBA. Wow, shocking, that didn't work. Well, now let's go to ABA by the same master's level provider or by another licensed mental health counselor. Oh, wow, that didn't work either. Maybe there's something wrong with the science of ABA. EPSDT. It's important that the MDT that we, any client with autism diagnosis that she touched on, that's medically necessary. It does seem like a delay to services when that is administrated. Healthcare licensure laws, let's delay it to debate it. I don't think many people understand exactly what that's going to do. I talked about the signatures of the EBD. I'll also read 2 sentences from a blog on ABA, phasing out ABA. This is why you want BCBAs, not LMHCs doing this. Our ABA provider thinks my son is ready to start phasing out after just 1 year of therapy. He is doing much better than when he started. The difference is very noticeable. Thank you.
Thank you. Aaron Wagner? Anything else?
Okay, so CPT codes. The we've talked about this. I've made comments before about the licensed mental health counselors. I am a licensed mental health counselor. I'm also a BCBAD. I think the licensed mental health counselors who do not meet criterion to be supervisors of paraprofessionals should themselves then be supervised by a BCBA. I would recommend it at the BCBA level, but I understand that may not apply. But the object is that behavior analysis is different from mental health counseling. That is evidenced by the CPT codes. This year, January 1st, CPT codes were approved, final CPT codes. My staff noticed yesterday that CPT codes are in the system. Are you planning on using the CPT codes?
No, all CPT codes are in our system.
Okay, so but you're not choosing not to use them. Okay.
They just get automatically loaded from CMS, so that just kind of puts it toward the system.
Okay.
So yeah.
So, but the realization, also that what Colin spoke about is having multiple people. Those of us that serve the very challenging individuals, there are CPT codes. There were temporary codes before. There isn't a code within behavior analysis in the behavior analysis services. Sometimes we need more than one person. And then last thing. Still not getting paid for group and individual on the same day. I have to use 4 staff to get some of the services done for our individuals because of the limitations of hours that are artificial. They don't come from the field of applied behavior analysis, but RBTs are limited to 5 hours a day of individual. They can't do individual and group on the same day with the same individual. Group, you guys are taking that as individual hours. So if I have 3 people, and I have a staff working with those 3 people, it's 3 hours, and then that person can't bill anymore, but I'm paying them for a whole day. So, and the EBD for facility-based services is another question.
Thank you. Sharon Older?
Yes. I don't want to go up there. Okay. Just talk from here, as long as I can just talk from here. I just want to go back and clarify and ask more questions, not like present. The provider types, if we have behavior analysis as part of the TBOS array of services, but most TBOS right now is a type 05 provider, and behavior analysis is a type 39. Will any provider types have to change, or they'll just be listed?
No, so the provider types won't change.
Okay.
We'll just, under the section where it says who can provide, we'll just make a delineation about who can provide what service. So you'll see that we'll say who can provide, and it'll have like a subheading, we like do or whatever. We'll say TBOS providers, and then the next thing will be applied behavior analysis providers, and then above that
subtract her amount of
time.
Reclaiming her time.
Okay, so anyway, so we're gonna make sure that there's a clear distinction, we understand who
Okay, well, the corollary to that question is my recommendation then would be to take behavior analysis out of TBOS. Don't have it there. Have TBOS be mental health services and have behavior analysis.
Thank you
Here's the reply.
I'm here. I know y'all are probably sick of me. So is everybody else in the room. And thank you for hosting this. We do appreciate it as practitioners. I'm personally sorry if I came off as aggressive or rude. I couldn't talk until I was 5, so I'm still learning how to talk. So if you, any BCBAs in the room, if you need another client, I could probably use some help. But on top of that, the founder of our science, B.F. Skinner, did write a book called Verbal Behavior. And a lot of things like OT and PT, they're great, and we could probably teach a lot of those same skills through ABA. It's a different methodology, but we could probably do it. So while I agree that ABA has to be the most important service for children with extreme maladaptive behaviors, simply needing skill acquisition should not be a disqualification for ABA services, because we can work with those things, and we would love to be able to coordinate with SLPs or any other professional to help a mutual client. But that's simple skill acquisition, especially when kids need social skill development. If you have an awkward teenager, kind of like I was probably, then they need that help just as much as anybody. So simple skill acquisition, just because I'm not whacking you in the face, although anybody in here, I'll whack you if it means you get services for me. You know, that should not be an automatic disqualification for services, but under EQ Health, it pretty much is.
Thank you. Stacy Frazier?
Yeah, that's me. Just one thing, and I'd like to piggyback on this is great. That you guys provided that you basically opened it up. Yeah, so that's wonderful. I think that some of the discrepancies with policy and the fact that we're not all clear on it, does have to do with EQ Health. And maybe, is there a way that you're able to judge efficiency and what they're doing? Like you guys were saying that you like data. It would be really interesting that that instead of the onus being placed on the provider, that it's placed on the paid partnership that you have, so that you're able to make sure that they're not confusing your providers by the policies that you're presenting, where there's, you know, undue animosity when it's not necessarily what you're presenting, but the way that your partner is bringing it back. Does that make sense?
It does. So thank you for bringing that point out to us, because we can't work with them and get things approved if we don't know. You know, I know that we would like you to work with them and through them, but if that's not working to help you resolve your concerns, please do reach out to us. And again, I know I've said it before, but using the complaint hub does help us. We are open, and that's really how we hold our health plans accountable. That's how we figure out how to hold our vendors accountable for things that should not occur. Because
they provide any reporting back to you, like
they
how many
do.
times
They do. We get weekly reports to that effect. You know, so we see how things are coming in. You know, but again, like we only can see one side of the story, right? Because we're hearing that the documentation that's being submitted isn't sufficient. It's not clean. It's not accurate. That there are lists of prescription. There's like prescription pad document that all of these physicians are using that just circle ABA and maladaptive behavior and sign it's the same form letter. We're hearing that the behavior intervention plans are, you know, cut and paste. It's just you're changing the child's name and adding a different goal. So just like you're giving us feedback and input, we're hearing from them. But in order for us to have the full picture, we do need you to use that complaint hub so we can see the individual things, so we can dive deeper into that. So I see Sharon nodding her head, because when she lets me know things like that, we're able to hold them accountable and get questions to get it resolved. So I don't, you know, if you tell us these things like now, it's great to hear, but it's better for us to be able to help resolve it by having more specific and detailed information.
And I'm just we're together. But are they audited on that stuff? So like if you're pulling the data on it, like you guys audit.
We have a monitoring plan, yes. So there's a contract manager, there's a monitoring plan, yes.
I think those things are helpful for providers to know, right? Because we have no idea the activity between you guys, between EQ Health, how much you kind of know. So it's that kind of transparency is great. And when they're picking back stuff that doesn't fall within your policy, it is alarming to us saying, did something change? Are we not aware that something, because this didn't get kicked it back, you know what I mean? So that's why it's.
Nikki Dickens crossed it out, the one to check.
Oh, I thought we were waiving our speaker, the whole formal. I really appreciate Ms. Thomas's, earlier you said access and holding these meetings, but I'm also concerned, and I'm Nikki Dickens, I'm sorry, about the limited venue of 150 attendees, the alert that just came out for next week's Orlando meeting.
Did you see the fact that we had a wait list there? So
no, so we're getting a lot of questions. I want to make sure that the message is clear.
So to be clear, there's a wait list. So if there are more people interested in attending, we will host a subsequent meeting.
Okay.
We're going throughout statewide. It is very challenging for us to find venues. We are asked as state workers to use state buildings, and they just do not have that size to accommodate. So we did have to find a venue where we were able to pay for that. And that was all that we could find to continue to be able to host these meetings. So to be able to do that, we're willing to have a wait list. So if the wait list is a substantial wait list, of course, we'll schedule and plan another meeting so that we can hear from the public, because that's our intent, you know.
Okay, and I figured that was the motivation. There may be subsequent meetings after that initial scheduled. So, but that's good. Very nice to hear that.
Okay, well, I'm sorry, what was your last name?
Nikki Dickens.
Okay.
Baker rate?
Yes, I know we're running short, so I just wanted to say a thing about the simplification. I understand the drive to simplify language and to simplify the process. I'm concerned, however, in that drive to simplify that you're losing the individual benefits of all of the individual pieces of that which you're simplifying. So the word up there that says determining when a duplicative service has already been provided on the same day, I would suggest that behavior analysis and counseling aren't duplicative. I would say that they're separate, and in many cases, and in some cases, additionally helpful. So I think in trying to simplify things, there's a great potential harm of devaluing those individual services as we treat them all the same, because they're not. I believe that you mentioned earlier that OT, you don't determine modalities. The OT has its own
They do.
thing.
Yes.
So I would suggest that ABA is its own thing. And I would suggest that mental health counseling is its own thing. And that you're not determining modalities of behavioral treatment by, I would say that you're limiting the benefits of those things underneath that umbrella. When you do that, because you don't see them as the same thing. We have individuals that we serve where we work and speak with their mental health counselor. And we work and speak with their speech therapist and with their occupational therapist. And at no time would I ever believe that it's duplicative. I would say that it is, they both, ABA, OT, they have their own lane. And as long as we stay in our own lane, we're going to be the best for these individuals that we're hoping to serve.
Thank you. Jane Johnson?
Absolutely.
Okay, thank you. All right, that's all.
Well, thank you for your time today. Thank you for your comments. Thank you for your feedback. And again, if you have a question, the overall changes to your analysis, you can send it to VA comments, but if it's also rule, please send them to the rule mailbox. So thank you.
Thank you.